Thank you for your kind introduction. Today my topic is fascicular VT. What is the mechanism? Let's start with a case. Mr. Gu is a 20-year-old gentleman who had on and off palpitation for 3 years. He had a palpitation around 5 to 6 episodes per year, each time lasting from 2 hours to maximum a day. He visited emergency department during palpitation with ECG recorded Y complex tachycardia. Echocardiogram was done which showed a structurally normal heart. So this is the ECG at the emergency department, which showed a typical RBBB morphology together with the left axis deviation. Cardioversion was performed. After successful cardioversion, the ECG showed a normal sinus rhythm with narrow QRS. There was no underlying RBBB or any left axis deviation. So what is your differential diagnosis and what would be your management plan? Important differential diagnosis for Y-complex tachycardia include 3 important mechanisms. The first one would be SVT with aberrancy. It could be AVNRT, orthodromic AVRT, or AT with aberrancy. The second would be pre-excitation or accessory pathway. The accessory pathway could participate in the tachycardia, that is the antidromic AVRT, or it could be a bystander with underlying SVT. The third mechanism would be ventricular tachycardia. Actually, if you are very familiar with ECG, then this ECG is typical of tachycardia originating from the left posterior fascicle. This is because the RBBB morphology suggests the tachycardia originate from the left bundle, while the left axis deviation suggests the tachycardia originate from the left posterior fascicle. The important differential diagnosis would be left posterior fascicular VT, or theoretically, it could be an SVT with underlying RBBB together with left axis deviation. Because the underlying ECG do not have any underlying RBBB or left axis deviation, so posterior fascicular VT would be top in the differential diagnosis. We can also try to differentiate whether this is VT or SVT by Brugada algorithm. This algorithm tries to differentiate VT from SVT by whether the ventricle is activated via the septum or not. It consists of 4 steps. Let's try to apply it to our case. The first step would be looking for any concordance in the chest lid. In our case, V1 is positive and V6 is negative. So there is no positive or negative concordance in the chest lids. We proceed to step 2, which would be the RS interval in the chest lid. In our patients, the RS interval is less than 100 milliseconds. So we proceed to the step 3. The third step would be looking for any AV dissociation. In our ECG, we could not see any discrete P wave, could not see any fusion beats or capture beats. So this ECG did not show any AV dissociation. And then we go on to the last step. The last step will be looking for any atypical RBBB or LBBB morphology. So to identify what is atypical, we need to know what is typical first. For typical RBBB morphology, we would expect a total right rapid ear and a septal R wave in V1 and also a septal Q wave in V6. This is because for patients with RBBB, we expect the septum would be activated from the left side. So we would expect an initial small positive deflation at V1, that is the small septal R wave, and also a septal Q wave at V6. However, this patient do not have any septal Q wave at V6. Instead, he had the RS pattern in V6. Together with the left axis deviation, according to the Brugada algorithm, this patient is more likely to have VT. However, bear in mind that no algorithm can be 100% sensitive or specific. As the concept of Brugada algorithm is to differentiate VT from FVT by whether the ventricle is activated via the septum or not. That means if the patient have a septal VT or fascicular VT, it can be misclassified as SVT. In other words, if the patient have an antidromic AVRT with the ventricle activated via the myocardium, it can also be misclassified as VT. So we need to have a comprehensive differential diagnosis in our mind. So this is a very important table which shows the differential diagnosis of Y-complex tachycardia by the three mechanisms, while the table on the right-hand side shows the specific differential diagnosis for patients with Y-complex tachycardia together with a typical bundle branch morphology. For our patients, as discussed, because of the RBBB together with the left axis deviation, the top differential diagnosis would be a fascicular VT. A theoretical differential diagnosis would be SVT with aberrancy or rarely an antidromic AVRT with the accessory pathway directly inserting into the left posterior vesicle. So with all the differential diagnosis, if we can rule out any pre-excitation in the underlying sinus ECG, then we should consider isoptin for our patients, because which will be very useful for fascicular VT and also SVT with aberrancy. Also, please note that all these Y-complex tachycardia with bundle branch block morphology could be effectively treated by catheter ablation. So please remember that for patients with Y-complex tachycardia, together with typical bundle branch block morphology, we may consider isoptin, which would be useful if the baseline ECG do not have any pre-excitation. Secondly, if the patient is symptomatic, we should refer the patient for EP study and ablation, but not ICD implantation. So our patient was subsequently arranged the EP study and also the ablation. This is the baseline EGM of the sinus rhythm. The Y-complex tachycardia can be readily induced by ventricular extra stimulus. This ECGM clearly demonstrated AV dissociation. Let's take a closer look on it. So according to the surface ECG, the timing of the V can be clearly identified as below. And on the RA catheter, we can clearly identify the local A signal. And in this EGM, there is clear A and V dissociation. So the diagnosis would be ventricular tachycardia. As discussed, this patient is likely having a posterior fascicular VT. Therefore, we proceed to mapping of the fascicular VT via the transeptal approach with HD grid catheter. When we place the HD grid catheter at the posterior septum, we could identify a very nice potential before the QRS complex, traveling from distal to proximal. This is the P2 potential. So this is the propagation map during the ventricular tachycardia. Sometimes this 3D mapping can be useful for us to identify the earliest activation point. So we proceed to ablation targeting at the P2 potential. As shown in this EGM, you can see that the P2 potential cannot be identified before each QRS complex. This is because the catheter was not very stable. During the third ablation targeting at the P2 potential, the ventricular tachycardia is transiently terminated. However, the tachycardia can be easily induced again after the ablation. Since the catheter position is not very stable, we decided to switch to retroaortic approach. So this is the fluoroscopy showing the ablation catheter via the retroaortic approach. When we place the ablation catheter at the posterior septum, again we can map the nice P2 potential before the QRS complex in the sinus rhythm. And as you can see, during the catheter manipulation, VT is readily induced. What's more is that before the P2 potential, we could recognize a very small potential before P2. This is the P1 potential. It traveled in reverse direction as P2, and it can only be recorded during ventricular tachycardia, but not during the sinus rhythm. It is very important for us to identify this P1 and P2 signal because they can guide our successful ablation. And sometimes mild potential can mimic this Purkinje potential, and ablation at the mild potential would not be successful. As seen in this EGM, we grab the chance to ablate targeting at the P1 signal, and the ablation is very effective. The ventricular tachycardia is terminated within 1 second of our ablation. After successful ablation, we could see a small delayed P1 potential behind the QRS complex. We will talk about the mechanism of this later. This is also important because it marked the endpoint of our successful ablation. So this case demonstrated that fascicular VT can be effectively treated by catheter ablation, and ablation at P1 site is very promising. So it is very important for us to know the mechanism of fascicular VT, which could guide our successful ablation. Fascicular VT is the most common VT, idiopathic VT at the left ventricle. It is recurrent tachycardia typically seen in young patients without structural heart disease. Fascicular VT can be classified into 5 subtypes. The most common would be the left posterior fascicular VT. Other types include the left anterior fascicular VT, upper septal fascicular VT, posterior papillary muscle VT, and anterior papillary muscle VT. They can be classified according to the QRS morphology and the site of the successful ablation. So what is P1 and P2 signals, and how do they guide our mapping and ablation? We really have to thank our previous EP giants who have worked so hard on fascicular VT. They discovered the presence of the P1 and P2 signals and their mechanisms in the tachycardia. That's why now we can confidently ablate fascicular VT. Back in 1979, Dr. Douglas Sipes already postulated that there is a common physiological entity near left posterior fascicle leading to this tachycardia. He had 3 patients with VT with RBBB and LAD pattern, which could be induced by atrial stimulation, and all the patients do not have any structural heart disease. And then 2 years later, in 1981, Dr. Bernard Behessen postulated that this VT entity was rarempamil sensitive because he had a patient, also structurally normal heart, with VT with RBBB and LAD morphology with recurrent VT attacks. All the attacks failed lignocaine and amylin. However, all the 7 attacks respond very well to rarempamil. His finding is very important because it guides our medical treatment for fascicular VT afterwards. And then in 1993, Dr. Nakagawa found that this fascicular VT can be successfully ablated at the Purkinje potential. He had 8 patients with fascicular VT, all with a small potential at the left posterior septum apical part. The potential was around 15 to 42 milliseconds before the QRS complex. During the tachycardia, he could terminate the ventricular tachycardia by ablation at this potential in all his 8 patients. This was a very important finding, as it suggested that this tachycardia can be readily mapped and treated by catheter ablation. He also noted that pace mapping was not useful in fascicular VT because pace mapping could capture the surrounding Purkinje fibers, so the morphology would not be accurate by pace mapping. In year 2000, Dr. Nogami first demonstrated the mechanism of left fascicular VT by entrainment and reset maneuver. In his paper, he demonstrated that there was a diastolic P1 and a pre-systolic P2 potential before the QRS complex, traveling in reverse direction during ventricular tachycardia. But only P2 signal can be recorded during sinus rhythm, like in our case. This is the proposed mechanism. During the tachycardia, P1 is the entry site from the slow conduction zone to the left posterior vesicle, while P2 is the exit site to the myocardium, which is actually bystander of the circuit. Therefore, during ventricular tachycardia, P1 travel from proximal to distal, while P2 travel from distal to proximal. But why P1 cannot be seen during sinus rhythm? So this is the explanation. During sinus rhythm, the activation was from atrium down to the ventricle via P2 and exit as QRS. At the same time, the P2 signal can travel retrogradely to P1. However, at this timing, P1 is merged in the QRS complex, so it cannot be seen during sinus rhythm. After successful ablation, P1 can be seen as a delayed potential after the QRS complex. This is because after successful ablation, P2 cannot be traveled retrogradely back to P1. However, it can travel slowly through the slow conduction zone to the P1. At the time when it reaches P1, it is already after the QRS complex, so it can be seen as a delayed potential after QRS. This is important because it is one of the endpoints of successful ablation. So back to our case. During ventricular tachycardia, we can map the nice P1 and P2 signal before the QRS complex, which traveled in different directions, while in sinus rhythm, only P2 signal can be recorded. And in our case, after successful ablation, we can map a delayed P1 potential after the QRS complex. Nogami also noted that in 1/4 of his patients, P1 signal cannot be detected. In this group of patients, ablation was successful, targeting at the P2 signal. In year 2016, Dr. Liu tried to postulate why P1 signal cannot be recorded in some of the cases. He suggested that if the P1 is very short or not parallel to the left posterior vesicle, then it cannot be detected. So I have encountered 4 cases of fascicular VT. Today's case is the one with a very nice P1 and P2 potential. 2 other cases could be successfully ablated, targeting at the P2 signal, while one case was really difficult and required linear ablation of the left posterior vesicle. For difficult cases, one of the main issues was the contact problem. This is because the catheter was very difficult to maintain contact with the contracting heart every heartbeat. In some paper, it is suggested that transeptal approach can improve the contact force, while the retroaortic approach can improve the stability. Like in our case, initially we attempt ablation via the transeptal approach, but the catheter was not very stable. Therefore, we switched to retroaortic approach, in which the catheter became much more stable and the ablation was much more effective. Some papers suggested that for difficult contact, we may also consider cryoablation for left posterior fascicular VT. However, for some refractory cases, alternative diagnosis like a papillary muscle VT have to be considered, and in such cases, ice-guided ablation may be useful. So this is the typical fluoroscopy and 3D site for showing the site of left posterior vesical linear ablation. Knowing this anatomy is useful for fascicular VT ablation. Please be reminded that the ablation should be targeted at the distal 1/3 of the posterior vesicle, because if ablation at a more proximal location, it may be complicated with left bundle branch block and long-term heart failure. So, ladies and gentlemen, in the last 20 minutes, we have talked about the 3 important mechanisms of Y-complex tachycardia and the specific differential diagnosis for Y-complex tachycardia with bundle branch block. Please be reminded that for Y-complex tachycardia with typical bundle branch block, isoptine is useful if the baseline ECG had no pre-excitation. Also, for patients, for symptomatic patients, EPS and ablation should be considered, but not ICD implantation. We have also talked about the mechanism of fascicular VT and also the approach to successful fascicular VT ablation. I would like to grab the chance to thank the EP team in United Christian Hospital and Korea University Medical Center for their guidance. Hope everyone enjoyed the case, and thank you.